Good afternoon, one and all. My topic is refraction and children with special needs. I'll be speaking about common ocular issues associated with children with special needs, certain adaptations or modifications that you have to make into your conventional techniques of assessment, and some case-specific considerations. Children with special needs have certain additional challenges apart from your typically developing children, like they may have communication barriers, sensory issues, motor disabilities, short attention span, etc. But the prevalence of ocular impairment is very high in this group, and it often goes unnoticed or undiagnosed because most of them think that it is very difficult to assess these children. But to my experience, I believe with patients and with modified conventional techniques and in familiar surroundings, no child is untestable. So I will start with assessing visual acuity. An ideal setting for assessing these children would be their rehabilitation center or their special school. And if you can get the assistance from their caregivers or special educators, that would be an added advantage. You may start assessing vision binocularly and introduce the test as a game. Once a child gets used to the assessment, then you can ask the caregiver to occlude one eye. A child may resist wearing a typical trial frame. You can use some fancy kind of trial frame, so the child may be curious to wear it. Then for assessing visual acuity, you can use preferential looking tests or some matching cards. Whenever possible, you should do a cycloplegic refraction. Home eye is preferred. And objective refraction may not be that easy. You may use loose lens or a lens rack. The first picture shows a lens rack. I personally use it. It's very comfortable. You needn't change the lens often. It has a series of power like in 0.5 steps on one side and 1 diopter steps in other side. You have lens rack for plus and minus. So it's easy. You needn't change the lens often. You can just use it as a rack. Then coming to specific consideration, specific cases, Down syndrome, this kind of children you get often in OP. Assessment is comparatively easy in these children when compared to other groups. They cooperate well. But the real challenge is in dispensing spectacles. Their flat nose bridge and small ears or their facial features may pose challenges in dispensing. So you can use customized spectacles like the one without temples, and the second picture you can see with an additional nose bridge which align with their flat nose. Good compliance is very, well-fitting spectacle is very important in good compliance to spectacle. Now coming to cerebral palsy, the child may have poor neck control, associated motor disabilities, speech delay, etc. In these kind of children, you should specifically look for refractive errors, extraocular motility issues, and in specific accommodative response and cerebral visual impairment. Keep the child in their most comfortable or stable position while examining. That ensures their cooperation. Then examination room should be distraction free and dynamic retinoscopy should be done all whenever possible. These children may have the accommodative lag is highly prevalent in children with cerebral palsy. So most of the interventions or therapies are aimed at near vision tasks. When the child have an accommodative deficiency, during therapy sessions, while doing near work, they develop ocular fatigue or asthenopic symptoms, and these children may not be able to express themselves, so it presents as temper tantrums or inattention, or they don't like therapy sessions, etc. So whenever you feel there's an accommodative lag after performing dynamic retinoscopy, plus lenses has to be prescribed as single vision for near or as bifocals, depending upon the age and activities of the child. Then red flags that you should be aware of in cerebral visual impairment is the caregiver or the parents may complain that child have difficulty in identifying familiar people. That indicates a reduction in contrast sensitivity. So you should assess contrast sensitivity. Child may have difficulty with visual clutter. When too many things are shown and if you ask them to pick one thing, they may find it difficult. And child may have preference for objects which are moving. They may respond to objects which are shown on some side of their visual field. They have color preferences, or they may be more interested in familiar objects rather than exploring new ones. So coming to reduce contrast sensitivity, you can use an hiding heady low contrast test chart, and this is especially applicable for speech therapy sessions. When the child have a reduced contrast sensitivity, and if they find difficult to understand the facial expression, the lip movements cannot be read by the child, and that can affect the speech therapy session. So the solution is, if you find there is a decrease in contrast sensitivity of the child, you can advise the speech therapist to use a bold colored lipstick, or even if they are using an app, the contrast can be enhanced in the app during the therapy session. That makes them easier to understand the lip movements. Here, the child have problems with visual clutter. In the first picture, there are too much of information that the child finds it difficult to identify the main character. So you can mask the surroundings so the central characters can be highlighted. And even when you assess for visual acuity, you can use single optotypes so that clutter can be avoided. Then autism spectrum disorders. I think this is the most difficult group to assess because most of them are nonverbal, hyperactive, and poor attention span. But these kids are associated with accommodation convergence difficulties and refractive errors. Prefer a quiet room and don't use too much of light or sound because they get irritated when they are stimulated. So always make them comfortable so that they will cooperate. In case of intellectual delay or global developmental delay, high refractive errors are often observed, and it goes undiagnosed because nobody bothers to have an assessment. So cycloplegic refraction and appropriate correction is very essential so that they can cooperate well with their therapy sessions. Hearing impairment, when child have an hearing impairment, they always depend upon visual cues for communication. So refractive error has to be appropriately corrected so that they can perform well. And some cases may be associated with night blindness, so that also has to be addressed. In premature babies, you should expect high myopia, and the need for long-term regular follow-up has to be emphasized. In ADHD and specific learning disabilities, they may be associated with accommodation convergence anomalies, and some specific learning disabilities may be a presentation of high functioning CVI. So when you speak of high functioning CVI, in cerebral visual impairment, children may be associated with other motor disabilities. So they have a low function. Low function cerebral visual impairment means their visual processing is on the lower side, it's on the first side. In high functioning CVI, child may not have some disability. Maybe if you look into the history, child would have had some perinatal risk factors and the child had come out unscathed without any disabilities. But once they come to a school level or an academic level, they find difficulty in, like, especially in geometry, writing certain letters. So it comes out as specific learning disability. In such children, you should assess visual motor skills also. In epilepsy and seizures, use hometropine. Avoid overstimulation during sessions because that might trigger seizures, and give breaks in between examination. So my key takeaways are: patience and adaptations will give you successful assessment results. Know the child's comfort zone. Use disability appropriate chart rather than their age appropriate chart, and give adequate breaks between the tests. Thank you.
Thank you. Thank you, ma'am. That is a very insightful talk regarding the practical